طيب احنا طبعا دلوقتي هننتقل لموضوع مختلف خالص بقى hypertrophic cardiomyopathy. يعني it is a fascinating disease for many years regarding presentation, the management, heterogeneous disease in everything, the genetic mutations. بصوت كده يا جماعة. Heterogeneous disease in everything, at the level of genetics, at the level of pathophysiology, at the level of clinical presentation, at the level of risk stratification and management, very heterogeneous disease. So what is hypertrophic cardiomyopathy? It is a disease characterized by the presence of increased left ventricular wall thickness, not explained by abnormal loading conditions. For example, not explained by hypertension or aortic stenosis. And when the wall thickness is more than 15 millimeter in one or more of LV myocardial segments, or more than 13 millimeter in first degree relative of someone with hypertrophic cardiomyopathy measured by any imaging technique. It affects 0.2% of adults. It has genetic and non-genetic etiologies. Up to 60% of patients, the disease is an autosomal dominant caused by mutations in cardiac sarcomere protein genes. And this is commonly associated with myofibrillar disarray. 5 to 10% of adults are caused by other genetic disorders, including inherited metabolic and neuromuscular disease, chromosomal abnormalities, and genetic syndromes. The most common locations of aortic septal anterior wall, so asymmetrical hypertrophy can be seen in 70%, basal septal hypertrophy up to 20%, concentric LVH up to 10%, and the characteristic form, which is Japanese form or Magayushi form, is apical form in less than 2%. And this is very common in Japanese, apical hypertrophic cardiomyopathy. The pathophysiology, which is responsible for symptoms, is due to left ventricular outflow tract obstruction, diastolic dysfunction, myocardial ischemia, mitral regurgitation, and at the end stage, patients might develop end-stage form due to systolic dysfunction. So hypertrophic cardiomyopathy is the most common cause of sudden death in young population. Heart failure occurs in over 90%. Chest pain, 25% to 30%, either due to imbalance between myocardial oxygen supply and demand, or due to compression of the septal perforators by the hypertrophied septum, and some patients can develop myocardial infarction. Syncope up to 25%, presyncope 20%, could be due to ventricular arrhythmias, which is very serious event, or could be due to obstruction during exercise, or could be due to vasovagal in some patients. Arrhythmias up to 30%. Ventricular arrhythmias are lethal event, and atrial fibrillation is common, which might lead to devastating event due to loss of the atrial kick with the development of rapid atrial fibrillation. Sudden death, the annual mortality rate is up to 1%. So this is classic cross-section for hypertrophied heart, characteristic for hypertrophied septum, which is hypertrophic cardiomyopathy. Electrocardiogram class 1, level of evidence B, we can appreciate the presence of left ventricular hypertrophy, diffuse ST-TOV changes. Classic form can be seen in hypertrophic cardiomyopathy. 48-hour ambulatory ECG Holter monitoring, class 1 level of evidence B, which is important in risk stratification to rule out the presence or absence of ventricular arrhythmias. Echocardiography is mandatory to assess LV wall thickness, associated abnormalities of the mitral valve and the left ventricular outflow tract, assessment of obstruction, which might seen with provocation only, doing Valsalva maneuver, for example, left atrial enlargement, assessment of diastolic function, assessment of systolic function. So echocardiography is important for diagnosis, and we'll see later other rules for imaging modalities for risk stratification. So you will find in patients with hypertrophic cardiomyopathy, asymmetrical septal hypertrophy, systolic anterior motion of the anterior mitral leaflet and the contact with the septum and prolonged contact of the anterior leaflet, the same degree, it is correlated with the degree of obstruction. So severe form of HOCM with obstruction, the same continue for a long time during systole, more than 1/3. Resting gradient more than 30 is enough for diagnosis of obstructive hypertrophic cardiomyopathy, and with provocation, when the gradient is more than 50, this identify patients with obstructive form of hypertrophic cardiomyopathy. The LV cavity is small, the septal immobility, the mitral valve abnormalities, prolapse, and mitral regurgitation is common abnormality in patients with hypertrophic cardiomyopathy. And you can appreciate in this apical 4-chamber view the hypertrophied septum, the classic form of HOCM, as well as ICD in the right side chambers, short axis view, diffuse hypertrophy involving the septum, and the parasternal long axis view, the asymmetrical septal hypertrophy. And down, you can appreciate the apical form of hypertrophic cardiomyopathy and diffuse contracts to the right in patients having hypertrophic cardiomyopathy. Do we need to do CMR in hypertrophic cardiomyopathy? Yes, it can measure left ventricular diameter, volume, ejection fraction. It can assess the apex very well to diagnose apical form of hypertrophic cardiomyopathy. In case of difficult diagnosis by echo, you can do CMR. And by doing gadolinium to assess for late gadolinium enhancement, to assess the presence of myocardial fibrosis, this is very important prognostic criteria. So CMR is one C recommendation by experienced operators to assess the presence or absence of HOCM and to the presence or absence of late gadolinium enhancement for myocardial fibrosis, because it's correlated with the prognosis, as we'll see later. So this is CMR for patients having hypertrophic cardiomyopathy, the hypertrophied septum, and to the right, the apical form of hypertrophic cardiomyopathy. Transesophageal echo class 1 level evidence C, perioperative recommended in patients undergoing septal myectomy to guide surgical strategy to assess the outcome for the surgery. Stress test class 2A to detect functional capacity, response to therapy, sudden cardiac death, risk stratification in patients with hypertrophic cardiomyopathy. Biopsy class 2B, nuclear imaging class 2A in patients if we are suspecting cardiac amyloidosis. CT if we don't have the facility to do CMR or contraindicated. Coronary angiography class 1 to rule out coronary artery disease in some patients, and also before doing alcohol septal ablation, coronary anatomy is very important to identify the septal perforators, which is going to be injected with alcohol. Genetic studies are very important, and genetic counseling can identify 50 to 60% of patients with hypertrophic cardiomyopathy, but it does not provide reliable risk stratification or identify high-risk patients if positive for hypertrophic cardiomyopathy. But the role of genetic test is to identify potential at-risk relatives for HCM. If you have patient having hypertrophic cardiomyopathy and the 30th-degree relatives have a positive genetic study, this is very important. If no mutation in a relative, so no further test is needed. But if the mutation is detected and it's positive, so this is a high likelihood of developing hypertrophic, and those patients should be closely followed up regularly. So now we diagnosed having symptoms suggestive of hypertrophic chest pain, dyspnea, pre-syncope, syncope, and work up starting from ECG, echo, CMR, 48-hour ambulatory ECG Holter monitoring. So how can we treat those patients? What are therapeutic options that we have? Medical therapy, septal reduction therapy, pacing, and risk stratification is important. Beta blockers is a cornerstone in the treatment. That's one level of and it should be titrated to the maximum tolerated dose and recommended as first-line therapy, but have not been shown to reduce the incidence of sudden cardiac death. Verapamil is class 1 level evidence B, titrated to maximum tolerated dose, recommended for patients who are intolerant or have contraindication to beta blocker. Disopramide, which has a negative inotropic effect, has a role which is class 2A recommendation, titrated to maximum tolerated dose, recommended in addition to beta blocker. Regarding septal reduction therapy, we have surgical septal myectomy and we have alcohol septal application. Which procedure for which patient? Surgery is class 1 level of evidence B. It is a procedure of choice, of course, in patients having obstructive hypertrophic cardiomyopathy, resting or provoke greater more than 50, who are in heart failure despite maximum tolerated medical therapy. Mitral valve surgery is usually required in 20 patients undergoing myectomy. The complications of this procedure, AV block, which might necessitate the implantation of pacemaker post-surgery, ventricular septal defect, aortic regurgitation. Mortality rate is 1 to 2%, and heart failure is reversible post-operative. But it should be performed by well-experienced cardiac surgeons in this type of surgery. So this diagram shows the site for the incision to do septal myectomy, the procedure which lead to increasing the outflow tract and relieve the obstruction in addition to mitral valve surgery if needed for some types of patients. Alcohol septal ablation is class 2A recommendation. It is an alternative to surgery when surgery is contraindicated or patients have serious comorbidities like advanced age, or in patients with HCM, left ventricular outflow tract obstruction and heart failure despite maximum tolerated medical therapy. So it's recommended in a specific group of patients who are not a good candidate for surgical septal myectomy. By injecting 1 to 3 cc of pure alcohol in a big septal perforator supplying the septum, it's similar to surgery in terms of gradient reduction and symptoms improvement. However, the complications rates can be complete heart block up to 20% and inducing large myocardial infarction. So this slide shows the big septal perforator, which should be delineated well before injecting alcohol to induce infarction in the hypertrophied septum, which will lead to decreasing the gradient. And we have to weigh the risk versus the benefit. Which procedure for which patient you have to look for. If you have a patient who's elderly, having comorbidities, limited expected lifespan, sedentary lifestyle, gradient is not too high, less thickness of the septum, so we might recommend ablation. However, in young patients, healthy, long expected lifespan, very active, very high gradient, greatly increased wall thickness, coexistent structural disease like mitral valve disease, which necessitate mitral valve surgery as well. So these patients should be sent for septal reduction by myectomy, not by ablation. What about pacing? Dual chamber pacemaker on 1994 was a modality for treatment class 2B recommendation in the guidelines by dual chamber pacemaker with sequential AV pacing to allow paradoxical septal motion, which lead to widening of the left ventricular outflow tract and the reduction in the gradient. And to facilitate medical treatment with beta blockers and or verapamil may be considered in selected patients with obstruction greater than more than 50, who have contraindications for septal alcohol ablation or septal myectomy. Patients with high risk of develop heart block following septal alcohol ablation or septal myectomy can also be subject to this type of surgery. If we compare the different modalities of treatment, we can see that the survival and the risk for sudden death is very significant with septal myectomy compared with septal ablation or with medical treatment. So the natural history for disease after septal myectomy is better compared with septal ablation. 2020 C guidelines on sports cardiology that class 3 recommendation, the participation in high intensity exercise in which there is a competition, because we know that commonest causes for sudden death during the sports activity. Last year, the AHA and ACC guidelines for diagnosis of patients with hypertrophic cardiomyopathy. And this is a very important slide because it summarizes the risk stratification for sudden death. Family history of sudden death from hypertrophic cardiomyopathy. If we have a history in a family, first degree relatives, one or more deaths at a young age, less than 50 years. This is very important. Massive left ventricular hypertrophy, more than 30 millimeter septum, detected by echo or CMR. Unexplained syncope, more than one episode, especially if recent history of syncope in young after excluding syncope due to neurocardiogenic vasovagal syncope, because this syncope could be due to ventricular arrhythmias. Hypertrophic cardiomyopathy with LV systolic dysfunction, if we have an ejection fraction less than 50%, detected by echo or CMR. LV apical aneurysm, which can be seen by echo or CMR. Extensive late gadolinium enhancement on CMR, as we said. This finding is very important, especially when involving more than 15% of LV mass. This is indicate myocardial fibrosis, which carry a risk for sudden death. The presence of non-sustained ventricular tachycardia on ambulatory monitoring. This is very important risk marker, especially for young patients. So they recommended this algorithm in management. If we have patients diagnosed with hypertrophic cardiomyopathy, we have to treat comorbidities according to guidelines. If the patients have an obstructive physiology graded more than 30 or 50 with provocation and having symptoms, we have to avoid vasodilators, avoid high dose diuretics, and starting with the cornerstone of treatment, which is beta blocker. If the patient is not tolerating beta blocker, we can give verapamil or diltiazem. If the patient is still symptomatic, we might add disopramide. And if still symptomatic, we have to consider septal reduction therapy. If the patients have structural disease abnormalities like mitral valve disease, then myectomy is recommended. Otherwise, if patients having comorbidities and not a good candidate for surgery, then septal ablation. Don't forget the indication for ICD, prevention of sudden death in patients who resuscitated from cardiac death, sudden death, or having sustained VT or PF. Those patients should be subjected to ICD implantation. If no, but having at least one of the following criteria: family history of sudden death, massive LVH, unexplained syncope, apical aneurysm, ejection fraction less than 50%. These criteria are considered class 2A recommendation to implant ICD. If no, look for the Holter non-sustained DVT. If yes, and he is young, in children, class 2A, and in adults, it's class 2B recommendation according to the non-sustained DVT alone. If the patients have an MR finding for extensive late gadolinium enhancement in CMR, ICD may be considered class 2B recommendation. If no, ICD is not indicated. And recently, we have a new drug which have been proved in a trial known as Explorer HCM trial, mavacamten. Mavacamten is an inhibitor of cardiac-specific myosin adenosine triphosphatase. And when randomized the patients to this drug compared with placebo, was associated with improvement in the peak oxygen consumption, as well as improvement in the NIHA function class. The secondary endpoints included reduction in the post-exercise left ventricular outflow tract gradient, as well as reduction in the biomarkers, which is troponin and NT-proBNP. So this slide summarizes the post-exercise LVOT gradient with placebo and with mavacamten, a significant reduction with using this drug, as well as the resting gradient, ejection fraction, no significant change, and Valsalva LVOT gradient, also significant reduction starting from 74 up to 24 with the drug compared with placebo. And the significant benefit also included significant reduction in NT-proBNP, as well as high sensitive cardiac troponin. So the conclusion and my take-home message that when we are suspecting hypertrophic cardiomyopathy based on clinical and etiological diagnosis, we have to do the workup, which includes echocardiography, Holter monitoring, CMR, cardiopulmonary exercise test sometimes indicated, and risk stratification for sudden death is of paramount importance in every patient. Treatment, pharmacological, as well as invasive. Invasive may be surgery or maybe septal ablation in the cath lab. And finally, genetic counseling is very important for every case of hypertrophic cardiomyopathy. Any question؟ أنا كده يعني خلصت يعني أي حد من
شكرا جدا لحضرتك يا دكتور. دكتور معلش أنا عندي سؤال لحضرتك. دلوقتي في عيانين الهوكم أحمد عيانين الهوكم اللي هو complicated by cardiogenic shock، أنا هتصرف إزاي، خصوصا إن الانوتروبس هنا هتبقى يعني استخدامها صعب شوية في الهوكم.
Very challenging and complex situation when you have a patient like this, but you have to search for any correctable cause. If this is due to ventricular arrhythmias, due to rapid atrial fibrillation, due to the use of vasodilators and diuretics, which lead to very low blood pressure and are not recommended in those patients, because those patients, when you giving high dose of diuretics or vasodilators, this will increase the obstruction and lead to low cardiac output. So first of all, we have to rule out any correctable cause, which can be treated. If we have arrhythmias, can be managed by cardioversion. Immediately, this will improve the outcome. If the patient is depleted due to the high dose of diuretics, so fluids can correct the situation. Some patients might develop infarction, could be responsible for cardiogenic shock. We have to look by echo. So it's very complex. Regarding how to use the drugs which increase, we are obliged to give vasopressors to build up blood pressure. But it's very important is to correct any reversible cause very quickly.
شكرا جدا لحضرتك يا دكتور. شكرا جدا.
صباح الخير يا دكتور، أنا ميري عاطف. ازي حضرتك؟ ميرسي على ال very comprehensive overview كده. أنا كان عندي سؤالين صغيرين. ما هو على حسب الالجوريثم اللي حضرتك عرضته، ان البيتا بلوكرز بنبتديها لو البيشنت سيمتوماتيك، صح؟ لو هو بيشنت اسيمتوماتيك خالص.
Yes.
We just follow up البيشنت او الفاميلي ممبرز، صح كده؟
الصوت راح ميري كده، ما سمعتش.
كنت بقول لحضرتك يعني لو البيشنت asymptomatic مش بنعمل حاجة غير follow up.
Asymptomatic, yes, usually a beta blocker just to improve the symptoms of the patient. It has no impact on sudden death, by the way.
اوكي. طيب والبيشنت لو هو بقى يعني لو في الليت ستيجز كده زي ما كان احمد ماهر بيقول و developed systolic dysfunction، ساعتها بندي ايس مع البيتا بلوكرز؟
Yes, we will treat him as a heart failure.
اوكي تمام. واخر سؤال معلش، هو لو البيشنت جاله لو عنده hypertrophic cardiomyopathy و atrial fibrillation، الانتي coagulation بيبقى يعني according للشادز بس؟
No. It's mandatory, yes. The stroke rate is very high in hypertrophic cardiomyopathy. I have seen young patients, children, develop stroke due to atrial fibrillation with HOCM.
Okay, so it's mandatory يعني regardless الشادز فاسك بتاعه.
No, regardless, of course.
Okay, thank you دكتور.
Okay. طب يا جماعه، واضح ان انتوا يعني مستعجلين وعندكم شغل تاني، فطبعا انا بشكركم. الحضور كان 22 واحد، يعني اوكي. يعني احنا في ايام امتحانات باين دلوقتي، ف سيمس ان الناس مشغوله، بس انا شايف يعني مجموعه متميزه من الحضور من الاسم، وبقيه الناس من بره الاسم. فبشكركم على الحضور، ونتقابل في محاضرات قادمه. شكرا جزيلا.
شكرا جزيلا يا دكتور، ميرسي جدا.
شكرا.